Hello and welcome, everyone. We will be giving attendees a couple of minutes to join, and thank you for being here with us today. So again, we're just going to give it another minute or so to have our attendees a little bit of time to join us. Again, thanks for being here, and we will start in about a minute. Hello, everyone, and welcome and happy Pride. My name is Tom McDermott, and I am the Senior Regional Resource Director at Caron Treatment Centers. Thank you so much for joining us for today's webinar on the topic, Treatment with Pride, Providing Compassionate and Culturally Competent Care for LGBTQIA+ individuals. As a reminder, we will be conducting this session in webinar format, meaning all participant microphones will be muted. We will not be able to see or hear you. During the presentation, please utilize the Q&A feature to ask any questions. If we are unable to get to your question before the end of the hour, we will have someone from our team follow up with you directly. Additionally, the slides and recording of the webinar will be emailed to you within 15 business days of the program. Today's presentation is eligible for 1 continuing education credit. We would like to thank our educational partner, CE Learning Systems, for assisting in providing these credits through co-sponsorship with the American Psychological Association. Please note that in order to receive your credits, you will need to be on for the entirety of the program and complete the post-webinar evaluation. A link will be emailed to you directly after the presentation from cego.com. After finishing the evaluation, you will have immediate access to your certificate of completion. In June 2022, Caron opened its LGBTQIA+ track. With higher rates of mental illness and addiction in our community, Caron opened its LGBTQIA+ track in June of 2022 to meet our patients' needs. We know that the LGBTQIA+ community experienced extensive PTSD and trauma and is 2 times more likely to develop more likely to develop a mental health condition or substance use disorder, and therefore requires specialized treatment. In order to offer clinically competent care to this group, we had 4 staff certified as Rainbow Advocate Educators, which requires 16 hours of training. Additionally, we have 11 staff certified as Rainbow Advocate Clinical Specialists, which requires 24 additional hours on top of the 16 for the RAE certification. Additionally, our trauma-informed treatment track includes treatment around internalized homophobia, the interplay of substance use and sexual orientation, family of origin and family of choice issues, reawakening a sense of the spiritual. Today, I am proud to introduce our presenter, Bethany Franklin. Bethany joined Caron in 2017, first as a therapist in the men's program, then in the opioid treatment program in 2018. Currently, she is a lead family therapist at Caron, Pennsylvania, as well as a therapist in our LGBTQIA+ track. Using her training and education coupled with compassion and empathy, Bethany supports her patients and families as they come to realize that a healthy, happy life in recovery is possible. Prior to Caron, she completed an internship at Children's Hospital of Philadelphia, working with young adults and adolescents with HIV and their families. She is a licensed clinical social worker and a certified advanced alcohol and drug counselor. Bethany is also trained as a Rainbow Advocate clinical specialist and is currently working on her doctorate in social work. I will now hand the presentation over to my friend Bethany to get us started. Thank you again for joining us today.
Thanks, Tom, for the introduction. And again, thank you all for being here today. I think this is a really important topic that we talk about. So a few of the objectives, things that we're going to be discussing here today are we're going to talk about the importance of supporting the mental health needs and treating substance use disorders for the LGBTQIA plus community. We'll talk about LGBTQIA plus terminology. We'll go through the LISTEN model, which is a great model for working with members of this community when it comes to really anything, but especially substance use disorders and mental health. We'll discuss internalized homophobia and transphobia and some ways to work with that, and then understand the pros and cons of a gender dysphoria diagnosis and what does that mean for someone. So I want to really start with the basics. So the acronym LGBTQIA+, sometimes folks get confused or are uncertain about what exactly the letters mean. So I just want to give you a few seconds and see how many of these letters you can identify, and then we'll go through them in a little bit more detail. Okay, so LGBTQIA stands for lesbian, gay, bisexual, transgender, queer, intersex, and asexual. And then, of course, the plus sign represents all of the other sexual orientations and gender identities that are not listed here. So pansexual, genderqueer, agender. Those are all terms that would fit under the LGBTQIA plus umbrella. And just remember that we may know what these letters mean, we may have an understanding, but everyone who identifies as part of this community has their own story and their own meanings behind identifying as gay or as bisexual or as queer. So we want to keep that in mind moving forward. And I also just want to kind of get everyone's brains moving. I know it's lunchtime, so we have a little true or false quiz just to get you thinking. So the first question is, all men who have sex with men identify as gay? This is false. So there are some men that might identify as straight who have sex with men for a variety of different reasons. They may identify as bisexual, pansexual, or something else. So not all men who have sex with men identify as gay. Number two, 16.7% of hate crimes are related to sexual orientation. That is true. The FBI statistics show us that a good portion of hate crimes are based on someone's sexual orientation. Number three, gender identity and sexual orientation are the same thing. That is false. So we'll go through this when we talk about the different spectrums, but essentially gender identity exists on its own spectrum and sexual orientation exists on a completely separate spectrum. So we'll talk about that more in the next few slides. And then the last one, transgender individuals always identify as gay, lesbian, or bisexual. That is also false. Again, two different spectrums for gender identity and sexual orientation. Some transgender individuals might identify as straight, they might identify as queer, or they may identify as gay or something else. So just wanted to, again, get your brains kind of moving and thinking this afternoon. So this is the gender unicorn, and I think it helps break down what some of these constructs mean that we're going to be talking about today. So if you look on the right-hand side, about halfway down, it says sex assigned at birth, and I want to start with that. So sex assigned at birth is essentially when a baby is born, the doctor says it's a boy or it's a girl. So we can be assigned female, male, and then some states allow for an other category or intersex. And intersex is essentially when the external genitalia are ambiguous and the doctor is unsure whether to classify the child as male or female. It could also be when external sex organs don't match internal sex organs and chromosomal DNA, and sometimes we don't realize that until a child is older. So that's sex assigned at birth. And then if we go to the top, we have gender identity. So regardless of what someone's sex is assigned at birth, they may identify or feel different ways, and this exists on a spectrum. So they might identify as a woman, they might identify as a man, they might identify as both genders, they might identify as neither gender. So there's really a huge spectrum to all of that. Gender expression is how they present themselves to the world. So do they present in a feminine manner, more masculine, both, neither, other? So that's all gender identity. And then when we talk about who someone's physically attracted to and who they're emotionally attracted to, that's when we start talking about sexual orientation. So again, completely different than gender identity. So they might be physically attracted to any gender, all genders, men, women, and they might be emotionally attracted to different genders. And this is where we start to talk about asexuality. So for someone who identifies as asexual, they might be emotionally attracted to one gender or all genders, but not physically attracted to that person. And this comes from the Trevor Project. I think it breaks down these scales that we're talking about a little bit more. So again, that illustration of biological sex existing on a spectrum, gender identity, gender expression, gender presentation, and how the world perceives us, and sexual orientation. So just noting that these things are all very fluid and that individuals may move in this spectrum from one day to another. So that's a brief introduction, but we have to talk about why is it important to have awareness around the LGBTQIA+ community. So in terms of this community, it's growing in the United States. So about 3.5% of the population identified as being part of this community in 2012, and we're at about 7.1% in 2021. And it's not that more LGBTQIA+ individuals are being born. We think that it's because more people are feeling more comfortable coming out and being more accepting of themselves as society continues to grow. So again, why is this important? So LGBTQIA+ adults are more than twice as likely to develop a mental health condition compared to their heterosexual or cisgender counterparts. So more than twice as likely. And transgender individuals are more than 4 times as likely to develop a mental health condition. There's a lot of harassment and rejection from close family members and friends. A lot of LGBTQIA+ individuals go through that. And in terms of substance use, LGBTQIA+ individuals are more than twice as likely to use illicit substances and almost twice as likely to develop a substance use disorder. So why is it? Why is it that these individuals are more likely to develop a mental health condition or a substance use disorder? There's a lot of stigma in terms of being part of this community. Just like there's stigma around having a substance use disorder or a mental health condition, there is stigma around being part of this community. And there's a lot of discrimination and prejudice towards this community. Harassment we're seeing at Pride events, all of the protesters that are there. Laws are now being passed in different states, barring transgender individuals from gender-affirming care. Basic denial of civil and human rights. Maybe it's not being allowed to shop at a certain store or go to a certain restaurant because of your gender identity or your sexual orientation. Those things are still happening around our country. Harassment and bullying, especially for youth. This is a very challenging time for them. Family rejection. So we have a lot of homeless LGBTQIA plus youth in this country. And it's because their families have rejected them and disowned them when they came out, and they're now living on the streets. And internalized homophobia and transphobia, the discrimination, the stigma, that rejection, all leads itself to internalized homophobia and internalized transphobia. And what we see happening is that then individuals from this community start to isolate as a protection mechanism to protect themselves from those outside forces. And what we know about isolation is that it really builds mental health disorders, it builds substance use disorder. So we start to see these individuals isolate to protect themselves, and then rates of depression go up. Rates of anxiety grow up. There starts to be problems in healthy relationships. So maintaining healthy relationships, developing new healthy relationships. And sometimes these individuals turn to unhealthy relationships in isolation. Substance use disorder loves isolation. And what we know is that now with the increase in technology in terms of cell phones and internet access, process addictions and addiction interaction disorder are even more prevalent. So someone might develop an addiction to online gambling or shopping, porn addiction. All of those things can be done in isolation. And the pandemic really did a number on the LGBTQIA plus community in terms of isolation. We were forced to isolate. And this community really depends a lot on support and solidarity from other members of the community. And being forced into isolation really pulled some of that apart and made it challenging for this community. So switching gears a little bit and talking about treatment and recovery for the LGBTQIA plus community and what does that look like? So I want to highlight the differences between cultural competence and cultural humility. I think cultural competence is one thing that probably a lot of us are familiar with. It's that ability to understand and appreciate someone else's culture or beliefs that are different from our own. And it's something that we want to make sure that we're constantly practicing, that we always are maintaining that cultural competence when working with other cultures. But cultural humility is an outlook that is other-oriented and respectful of the individual's background. And the important part about cultural humility is that it does not take the stance of being an expert. So cultural competence is that understanding, and cultural humility is saying, okay, tell me your story. You know yourself better than I could even understand. So please let me in and share your story with me. So culturally sensitive treatment, what does that look like? Is that, being discussed during assessments, the intake process? What can we do to make sure that treatment is culturally sensitive? We have to be aware of the intersection between culture and sexuality for clients. So someone's racial or ethnic background, that culture might intersect with the ability for them to come out or the feelings of comfortability around that. Meeting clients where they're at and accepting of their decisions. So we might think that a client should really come out to a close friend or a family member, but maybe they're not there yet. Maybe they're just not ready. And we have to be willing to accept where they're at. and voicing respect for their values, culture, and experiences. Really, it's about voicing respect for their story. And we want to communicate that to them. It's one thing to have respect for these things, but making sure that we're communicating to the client that we do respect them and that we are appreciative of them sharing their story. Treatment plans should incorporate cultural needs and issues. We should be willing to recommend culturally relevant resources to these individuals and have kind of a list of some resources we can send them to, and be sensitive to any limitations that these clients may face. So I think this really starts during intake, whether it's outpatient treatment or inpatient treatment, making sure that assessments are culturally sensitive and inclusive. So we want to ask open-ended questions and try to avoid putting people into boxes. So you want to ask those open-ended questions like, how do you describe your gender identity? Or how do you describe your sexual orientation? And allow them to share how they identify without putting someone in a box as heterosexual or gay or bisexual. Allow them to share how they identify. How do you describe your expression? How do you express yourself? What do you value? What do you think your therapist needs to know about you? There might be a lot of things that they disclose during that question that they don't disclose previously. And how do you think cultural factors influence your situation? That will give us a lot of information on the intersectionality between culture, gender identity, and sexual orientation. So I want to talk now about the LISTEN model, and this comes from ITAP, if you're familiar with that organization. But I think this is a great model for working with LGBTQIA+ clients. So we're going to go through this, and then I have a small case study where we'll talk about how to really apply this in a practice setting. So the L stands for listen. So this is providing that safe environment without judgment, where we're affirming the client and allowing them to express their feelings and be heard, really practicing those active listening skills. The I is imagine. So this is where we might ask reflective questions, where we encourage them to think about how life might be different if they make different choices. And it's not choices about sexual orientation or gender identity. Those things are not a choice, but choices whether they disclose their orientation to family members, choices about if they start presenting as a gender other than their own. How will life change or be impacted by those choices? The S is for self-determinism. So this is where we want to provide a supportive, affirming environment, no matter what the client chooses for themselves, and maintain that respect for the client, no matter what those choices are. Trust, continuing to develop that trusting rapport with the client, allowing for an open door of communication, allowing them to ask questions, and allowing for a safe space where they feel like they can ask those questions. E is for empathy. So continuing to demonstrate empathy, continuing to demonstrate compassion for everything that this individual has gone through. And the N is for next steps. So this is where we're going to have those resources available, whether it be recommending an affirmative treatment center, whether it be providing aftercare resources for an affirmative therapist, whether it be some books that we're encouraging them to listen to, or support groups that we want to connect them to. So that's the LISTEN model. And then this case study I made up, but I think it's a situation that some of us probably see in our practice. So Keith is a 35-year-old male assigned at birth and uses he, him pronouns. He presents to treatment wearing nail polish and clothes that are typically seen as feminine. He comes to a session sharing that he feels like both a man and a woman and is not sure how to identify. He also reports that he is married to a woman and is satisfied with their relationship, but that he has not been open with her regarding his current thoughts and feelings. Throughout his time in treatment, he reports that he has been more comfortable with sharing his identity with his peers and now identifies as queer. However, he reports that he still does not feel comfortable disclosing this information to his loved ones and peers outside of treatment. So that's the case study, and then we'll look at how we can apply this LISTEN model. So for LISTEN, it's providing that welcoming environment to make Keith feel safe. So I always recommend for therapists or other support professionals putting a pride flag in your office or displaying LGBTQ photos or other materials around the office or the building. Just lets the individual know that it is a safe place for them. And we're going to continue to listen to Keith without judgment and communicate that to him. For Imagine, it's asking those reflective questions. So Keith, what would it be like if you no longer identified as a man? How do you see life changing if you were to open up to your wife, if you were to share with peers? How might life look a little bit different for you? For self-determinism, it's providing that supportive and affirming environment no matter what Keith chooses. So as a therapist, we may really want Keith to disclose to his peers or to his wife that he now identifies as queer, and he just might not be ready for that, and we have to be okay with that. We have to be affirming of that. Trust, continuing to develop that therapeutic rapport, empathy. We're going to just continue to demonstrate compassion for Keith, empathy for him. Thank him for allowing us into part of his story. And for next steps, maybe it's pointing Keith in the direction of celebrities that identify as queer that can be role models for him. Maybe it's providing him with some books or a support group for individuals that identify as queer. So this is just some practical ways that we can apply this model with real life clients. And I do want to talk a little bit about internalized homophobia and internalized transphobia. So back in the 90s, Meyer and Dean conceptualized internalized homophobia. And they said that it's the homosexual's direction of negative social attitudes towards self. And I don't like the word homosexual. We're pulling away from using that word, but that's the word they use. So it's really this dislike for oneself, this dislike for one's sexual orientation or gender identity. And what ends up happening is the individual starts to reject that identity part of themselves. They start to really have negative self-talk, just like some others might be bullying and discriminating against them. They start discriminating against themselves. And it really decreases self-esteem and self-worth, and it can lead to a lot of relationship problems. So what do we do with internalized homophobia? So the first thing, again, just like a lot of this, is allowing for that safe space for the client to explore who they are without judgment. Letting them know that, yes, they may be going through some of these things. They may have been bullied for their sexual orientation or gender identity before, but this is a safe place to explore that. Promoting those LGBTQIA+ role models. If so-and-so can work through some of these things, maybe I can too. And it helps to restore that sense of hope for some individuals. And I think CBT approaches, cognitive behavioral therapy, really does a great job at chipping away at some of these internalized feelings. by combating some of those cognitive distortions, by asking those questions to chip away at those embedded belief systems. So that's a technique that therapists might use to ask some questions to get a little bit deeper and have an individual start to combat some of those distortions in belief systems. And gender dysphoria. So you might be familiar with this term. It's new as of the DSM-5. So the DSM-5 removed gender identity disorder and replaced it with gender dysphoria. And there is a bit of controversy surrounding this diagnosis, and we'll talk about that in a couple of minutes. So gender dysphoria, this is the criteria that someone needs to have to meet criteria for this diagnosis. So it's a marked incongruence between one's experienced or expressed gender and assigned gender of at least 6 months duration as manifested by. And then it has all of the following things. So it might be an intense desire to do away with primary or secondary sex features, a desire to have primary and secondary sex features of another gender, a profound need for society to treat them as another gender. And the last one here, this one is really important, but it should relate to clinically impairment or distress and affects the individual significantly socially, at work, or in other important areas of life. So gender dysphoria essentially is when someone identifies as a gender that they were not assigned at birth. So remember back to sex assigned at birth and then gender identity. When someone identifies as a gender that's different from the sex they were assigned at birth, they may present with these symptoms of gender dysphoria. And it tends to create a lot of emotional distress for the person. They might start to have relationship problems at work, and it really starts to affect someone significantly. So in terms of the controversy surrounding that, so past misuse of this diagnosis really disproportionately diagnosed individuals with psychotic or mood disorders to explain gender differences. And even though the terminology has changed in the DSM, giving someone this diagnosis still has the potential to stigmatize someone as mentally ill or as having a mental disorder, when in reality, it's just that their gender identity does not coincide with the sex they were assigned at birth. So there is some stigmatization there around giving this diagnosis. However, a lot of insurance companies will not reimburse for gender affirming hormones or gender affirming surgery unless the client has had this diagnosis for several months, sometimes even a few years. So if you're going to be diagnosing a client with gender dysphoria, my advice would be having a conversation with them around that, letting them know that it doesn't mean that they've got a mental health disorder, letting them know that it doesn't mean there's anything wrong with them, but that in order for them to receive affirming care, they need to have this diagnosis on their medical record. So then assessing for LGBTQIA plus inclusive services. So maybe you're working with a client that you want to refer to inpatient treatment, or maybe they are in inpatient treatment and you're looking for an aftercare provider for them, or maybe you're looking to get your loved one into treatment. What are some things that you can ask the admissions staff or ask that therapist about their services? So you probably want to start with what experience do they have with working with the LGBTQIA plus community? And do they have any specific trainings for working with this community, any specific certifications, or how does their education lend themselves to working with this community? Do they offer specific programming? And that is really important, especially in an inpatient treatment center. What we know from research is that LGBTQIA plus individuals tend to do better and have lower rates of relapse if certain topics are discussed during inpatient treatment. And in order for them to discuss certain topics, it may not be occurring in just a normal unit treatment group. And does the treatment environment allow for safety and open sharing? Is there a zero tolerance policy for harassment or bullying? So you really want to make sure that you're asking some of these questions when you're getting your loved one or a client into treatment. And to kind of summarize what treatment providers can do. So again, it's responding in an affirming way, in a supportive way when the client discloses their identity. And again, not taking the stance of the expert, right? Allowing them to be the expert in their own lives. Continue to validate, accept, and treat clients as they are. Advocate for them if they're mistreated. And then express disapproval of jokes and slurs when you encounter them, whether that's in your professional life or even in your personal life. Be mindful of the risks of self-harm. So just like mental health conditions start to increase when someone is a member of this community, so does the risk for self-harm and the risk for suicide attempts. Facilitate those connections with other members of the LGBTQIA plus community and support their self-expression. And providing resources is a really important tool. We can talk to our clients and validate their feelings, but sometimes they just need a little bit more. They need that connection to resources. So there's a bunch listed here. I encourage everyone to look at these websites or read these books before you recommend them to a client to see what you think is fitting. The Velvet Rage is a really great book for coming out for men in a straight world, essentially. And what are some of the challenges of that and how can we work through some of that? And Untamed by Glennon Doyle doesn't necessarily address sexual orientation or gender identity, but it's about self-acceptance. And how do we stop people pleasing and start accepting ourselves more and advocating for ourselves? And what can family members do? So, we all know that sometimes family members can be homophobic or not supportive, not affirming of their loved ones. My suggestion when I work with families like this is to really encourage them to not project those feelings onto their loved one, to not constantly bombard them with those feelings, because then they're at risk of losing that relationship with their loved one. They have a right to have the feelings and the opinions that they might have, but they don't have a right to project it onto someone else. So as a therapist, we might steer them towards continuing to get education on what it means to be part of the LGBTQIA plus community and how can we best support our loved ones that are part of that community. Send them resources, encouraging them to maybe get a therapist for themselves to work through some of that discomfort, and really avoiding stereotyping or misgendering. They may slip up with pronouns or stereotyping every once in a while, and that's going to be a growing process and a learning process for the family. But if it continues to be a pattern, again, they're at risk of losing that relationship with their loved one. So recovery is about connection. Family recovery is about connection. Personal recovery is about connection. So community support is really important. Just like we discussed how isolation is really a huge factor for the LGBTQIA plus community, community support is going to help pull individuals out of that isolation. So for the LGBTQIA plus community, if there's someone who's religious or spiritual, helping them find an affirming place of worship that's going to welcome them with open arms, where they can practice their spirituality or their religion freely. Many cities or towns have LGBTQIA plus community centers. They offer local support groups there. They do activities. They have events. Those are always a great resource to connect clients to. And health centers for this community. Not all medical professionals have the competency or the understanding to know how to treat some of the unique health needs that come up for this community. So we might connect them with providers that do know how to best support them. And support for family members. PFLAG is a really great resource. They have a lot of support groups, and PFLAG stands for Parents, Family, and Friends of Lesbians and Gays. They've been around for a very long time, and they have many, many support groups for families working through some of their own discomfort or want to learn more about supporting their loved ones. And sometimes those community centers also have family support groups there as well. So maybe it's connecting them to a support group at the local community center. And then there's the national network of LGBTQIA plus family groups at familyequity.org. So Caron's mission, like Tom shared a little bit at the beginning of this presentation, this started a few years ago. And what we started doing was mandatory training for all staff, whether it be clinicians, medical professionals, support staff, training on how to support individuals that are part of the LGBTQIA plus community. We started going through our documentation. How can we make it more inclusive? How can we make it more affirming? And then the important thing is providing those inclusive services, providing that affirmative environment, that safe environment for treatment and healing, which is what we did when we created the track about a year ago. Caron has had for many, many years weekend LGBTQIA plus retreats for individuals from the community to come to and do some more work. And then we have our breakthrough program here, which is a 5-day intensive that anyone can come to work on family of origin issues, trauma, healing. We started offering specialized workshops for the LGBTQIA plus community a couple times a year as well. So our track is really quite comprehensive. So patients come into treatment, and if they identify as being part of the LGBTQIA plus community, we will ask them if they'd like to be part of the track and of the programming. So there are 3 clinical groups a week, and each of those groups have different topics that we discuss during that time that research shows helps these individuals have greater chances of maintaining their sobriety. We have alumni speakers come in twice a month that identify as part of the community and share their stories with the current patients. There's individual support. If someone's not ready to be part of the group, or if they need a little bit extra support and some one-on-one therapy, we will do individual consults with them. Aftercare is important, and we want to make sure that we're sending our patients to an affirmative and supportive aftercare provider. So we will get involved in that as well. And then there's the monthly alumni group on Zoom. So any patients that have come through Caron that have been part of this track are welcome to join that support group on Zoom as well. So I want to thank everyone for being present and being very attentive, active, and engaged. This is the conclusion of my presentation, but we're going to go to questions and answers. So I'm going to turn it back over to you, Tom.
Thank you so much. Thank you so much, Bethany. And I just want to give you another shout out for the amazing work that you, along with the rest of the team, did to put this track together. I was honored to be part of it. It was a year-long journey, and I'd call it a journey because it definitely was a journey in order to offer this. And have seen some of the outcomes of clients that have gone through, and it truly is amazing. It kind of makes my unicorn heart warm. So, all right, Bethany. So the first question that we have is that, can you offer some guidance on working with homophobic clients, how to not meet intolerance with intolerance and to help them grow?
That's a good question. And I think as affirming therapists, sometimes we might struggle with working with those homophobic clients. And like I said earlier, they can have their own opinions and beliefs, but letting them know and kind of pointing out maybe incongruencies with their own beliefs and value system. How is treating someone in a homophobic manner or speaking about them in a certain way, how is that benefiting you? And how does that go against your own morals and values? And how would you want to be treated? Try to imagine yourself in a situation where you were treated as less than. How would that go for you? So we might not completely change their beliefs or their opinions, but we can point out inconsistencies with some of their beliefs and, let them know that certain language will not be tolerated in certain situations. And sometimes we have to have a zero tolerance policy for those things as well.
Thank you. So how does Caron handle living arrangements for this population, for folks that are in the track?
Yeah, so what we do is all of our units here, most of our units here, patients have roommates. And through our training, we learned that by not giving these patients roommates is kind of segregating them or othering them and making assumptions that we don't want to make. So when an LGBTQIA plus patient is coming into treatment, we will let them know that there's the possibility that they'll have a roommate. And if they're not comfortable with that, to let us know, and then we will not give them a roommate at no extra charge to them. And we also let all incoming patients know that there is the possibility that they will get an LGBTQIA plus roommate. And if they're not comfortable with that, they need to let us know so that we can make sure we're rooming these patients with someone that's going to be supportive.
And your trans clients?
And trans clients are given the option of if they would like a roommate or if they would like a single room. We used to always give them a single room, and they said that they felt othered by that. So now at this point, they get an option of if they'd like a roommate or a private room.
Gotcha. So when working with families of LGBTQ plus clients, when the family is homophobic and attributes it to religion, again, how to not meet intolerance with intolerance, and how do you help them grow?
So there are a lot of religious arguments out there in terms of why someone might be homophobic. And there's a lot of great resources. There's some documentaries, there's some books that kind of combat some of those religious arguments. And the Human Rights Campaign has a whole list of religious resources on their website that kind of poke holes in some of the rationale as to why someone's homophobic or not accepting of their family members. And I think we can gently try to steer them in that direction in terms of getting more education about what it really means to be LGBTQIA+, and letting them know, again, that they might have their own religious beliefs. And if they want to continue that relationship or maintain that relationship with their loved one, they're going to have to at least be supportive of them or affirming of them to maintain that relationship.
So could you offer some advice when doing family therapy with parents who intentionally misgender their child during a session?
Yeah. So if they're intentionally misgendering their child during a session, the first 1 or 2 times I would redirect it. I would point out that, this is their gender, this is their pronouns. You are not using the correct ones. And if it continues, I would say that the session might need to end early because it's not safe for that child. It's not productive for that child. And when they can use the proper pronouns and the proper gender terminology, then we will continue on with therapy, but it's not emotionally safe for someone to be subjected to that. So I would end the session.
I'm just curious, Bethany, have you experienced this firsthand?
I have experienced it firsthand. And what I have done is I've asked the parents to come in separately from their child and start to do some work and education with those parents about what is it really for them that is making this so challenging. And there were some other things that came up for them in this process, and they were able to come around a little bit better so that we were able to bring the child back into sessions with them.
So why do you think there is discrimination in the medical community against the LGBTQIA plus community?
So I wouldn't say that there's a lot of discrimination in the medical community. I mean, sure, there's some. I think that what it is more so is that medical providers aren't always being trained on the health needs of this community. So, for example, if you are a female and you go to the gynecologist, they might push birth control on you and talk to you about those options when maybe you identify as a lesbian. And so they just might not be educated on asking the right questions. They might not be educated on pre-exposure prophylaxis for men who have sex with men that might be at risk for HIV, or any gender who is having sex with someone who has HIV. So they just might not be educated on some of those nuances. They might have some fear around asking some of those questions because they don't want to come off as rude or unaware. And I think there might be some hesitation there. So I think it's just in general, we could do better at educating medical providers a little bit better about some of these needs.
So could you explain asexuality a little more?
Sure. So asexuality is when someone does not have a sexual attraction to anyone else, no matter what the other gender is. Asexual individuals would be totally satisfied without having sex with anyone for the rest of their lives. They may have emotional connections with someone else. So they might be emotionally attracted to other individuals and they might want to have a loving, committed relationship, but they might not be interested in sex. So that's where asexuality comes into play.
I'm looking at a question in the chat that says, when another patient in the waiting room comes back for their appointment and makes statements about the other client's gender or questions what gender they are, what is the appropriate response without disclosing private information about the LGBTQIA client?
I would say that it goes back to HIPAA and confidentiality. And in reality, that client that's coming back doesn't really have, they might be curious, but they don't really have a right to know sexual orientation or gender identity of any other clients. And I would just respond with, just like everything you and I talk about is confidential, everything that I discuss with other clients is confidential as well. So I cannot disclose that information.
So what if I misgender someone and want to apologize? I recently read not to apologize because I am then asking for support and forgiveness, but I am personally would want them to hear and acknowledge my mistake.
Mm-hmm. That's a very good point, and that's a question that comes up a lot. I've spoken to a few transgender individuals, and they said to me that they prefer if someone makes a very quick apology and immediately corrects themselves. I'm sorry, I used the wrong pronouns, she, her, or he, him, not making it a huge apology, because then that becomes more about us. I'm so sorry I did that. Can you forgive me? That's taking away the whole point of misgendering them and apologizing. That's when it becomes more about us. So a very quick, I'm sorry, I recognize what I did, and we move on, is probably the more appropriate way to handle that situation.
Is it rude to ask someone what they identify as?
So I think that the best way to go about this is saying to someone, hi, my name is Bethany. My pronouns are she, her. what's your name and what are your pronouns? And that way, you know that you're not going to misgender them throughout conversations. You know their pronouns. I wouldn't, completely say to them, what's your sexual orientation or what's your gender identity, unless you're doing an intake assessment with them. And then I would say to them, listen, we ask these questions. We want to get to know you a little bit better. We want to understand all of your story. So how would you describe your gender identity? How would you describe your sexual orientation? And if you're not comfortable with answering those questions, that's okay. Just let me know.
So do you think the next DSM should make adjustments in terms of diagnosing LGBTQIA plus conditions?
So right now, the only one that's in there is the gender dysphoria diagnosis. Homosexuality was in the DSM until the 70s, and that was removed. I think that, insurance companies, I don't see them changing anytime soon. So I think gender dysphoria needs to stay in there. I just think we need to do a better job at communicating to our clients why they are being given that diagnosis, and remembering to affirm to them that it doesn't mean anything is wrong with them, but we're doing it really to help them get insurance reimbursements.
So is asexuality typically a result of sexual trauma or other boundary violations? How do you distinguish between the two?
Sometimes it could be a result of sexual trauma or boundary violations, and others, just like individuals that are born bisexual or born gay, some individuals are just born asexual. So there doesn't need to necessarily be that sexual trauma. If someone discloses to you that they're asexual, I would do a little bit more digging in a compassionate way about, have you always felt this way? Has maybe something happened in your life where you were previously sexually active and now you don't feel comfortable being sexually active? And that'll kind of tease out whether it's a trauma response or whether they were just born asexual without that sexual attraction to someone else.
I think we probably have time for one more question, but real quick, our friend Nancy wants to know the name of the book that you mentioned previously. She had to change devices. I'm not quite sure, Nancy, what book?
So there's two books I talked about. The first one is The Velvet Rage, and that is for men coming out in a straight world. And the second book is Untamed by Glennon Doyle. And that's a really great resource just for how do we stop people pleasing and be more accepting of ourselves.
All right, I think we can sneak one more question in. So how can we have the conversation about having to use legal names in some documentation as opposed to preferred names?
That's also a great question. And I think that just comes with having that open and honest communication, asking someone how they identify, what is their name, what are their pronouns, and then letting them know, just so you know, for insurance purposes, I have to place your legal name in the documents. However, I will always refer to you as your name. I will always use your correct pronouns. But in our legal documentation, because of insurance purposes, you will see this name there. It's something that we have to do, but I respect your name, I respect your pronouns, and I will always use the appropriate name and pronouns when speaking to you or about you.
And I'm going to ask one more question really quick. And when billing insurance and needing to identify a specific gender, male or female, any best practices for discussing with a trans client about the need to identify a sex assigned at birth?
I would say the same thing. I need to fill out insurance paperwork and they ask about a sex assigned at birth. I need to put this on here. I know you do not identify as this. I respect what you identify as. And for the purposes of insurance paperwork, I need to put your sex assigned at birth.
All right. Bethany, thank you again so much for this informative presentation, and to all of our attendees joining today. As a reminder, this presentation is eligible for 1 continuing education credit. Watch your email for a link for cego.com to complete your evaluation. I'd also like to remind you that the slides and recording of the webinar will be emailed to you within 15 business days of the program. Please stay connected with us for our next continuing education programs by visiting www.caron.org/webinars. In the meantime, please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admission to any of Caron's programs. Again, thank you for joining us. Have a great afternoon and happy Pride.